For the GI infections, certain people are prone to develop these GI infections. There are certain reasons for that. For example, the age. Certain age are more prone to develop infections. The extremes of age, the children and the elderly people. The personal hygienic conditions, the hand washing, the toilet facilities, the sewerage facilities and other things. Some people also claim about the presence of gastric acidity, which is a good barrier against the invasion of the organism and passing on to the small intestine. Intestinal motility also sometimes plays a role in the development of infection. The presence of microflora in our gut, which are actually the biofloras present in our gut, they play also a role in resisting the infection. Certain specific immunity which is provided in our intestine with the help of phagocytes, immune cells, B cells and T cells, and certain receptors found in the intestine for certain organisms. What our aim is, we want dead or alive, but alive is not an option for food safety. These are the organisms which pass on into our gut through orophycal route. The various infections which we can get present as enteritis, which is inflammation of the intestine, which may cause a physical damage by the invasion of the cells to the intestinal epithelium. The dysentery, which is damage to the submucosa, which leads to the opening of the blood vessels, and therefore the person would present with the blood and mucus in the stool. Gram-negative bacteria may cause fever as an accompanied symptom when they get infected. Let's see some of the organisms which are involved in the development of GI infections. Salmonellosis, Salmonella enteritidis. I'll take Salmonella typhi later in a little detail. It passes into our gut through poultry products use. There are 2,000 or so strains of this organism. It's a notifiable disease in the West, but in our part we probably do not notify to the concerned authorities. Strains help to trace public health problems to their source. The diarrhea lasts for around 8 to 24 hours after food consumptions. It may be self-limiting sometimes, with a low mortality in infants and elderly. Another organism is Shigella. Shigella dysentery. Primates are the reservoir for these infections. Contaminated water and food substances assist in the spread of the infection through orophycal route. 10 bacteria may be enough to cause diarrheal disease. This is the smallest dose possible of the organism which can produce the disease. Around 450,000 cases per year are reported in the USA. Symptoms may last for 2 to 7 days. Sometimes it may be self-limiting. The non-lactose fermenting gram-negative rod. There are 4 species: Shigella dysentery, Shigella flexneri, Shigella boydii, and Shigella sonnei. They are highly infectious. Infectious dose, again as I mentioned, is very low. Incubation period may vary, and symptoms can develop within 12 hours of the infection. It presents as a fever, abdominal pain, difficulty and painful defecation, blood-stained diarrhea. There may be bacteremia in few patients. Sometimes some patients present with reactive arthritis of 1 to 2 week duration. The Shigella dysentery can be associated with hemolytic uremic syndrome. Anti-motility drugs have been associated with toxic megacolon, which are not recommended these days. Self-limited, but treatment is recommended in severe cases. Then we have got the E. coli. This cartoon which shows, you ever heard of E. coli? Yeah, it's something get on the internet, which means this is an infection which may very rapidly spread. E. coli gastroenteritis, there are various types or species or subspecies of the organism. Enterotoxigenic, which causes watery diarrhea, usually we call traveler's diarrhea. Enteropathogenic diarrhea is seen in the infants. It's common in developing countries. Enteroinvasive is which invades the intestinal epithelium and produces dysentery. The person presents with the blood and mucus. Enterohemorrhagic, in this condition we have got the copious blood-stained diarrhea, sometimes with the hemolytic uremic syndrome, and enteroaggregative. Some detail about enterohemorrhagic E. coli. Most common is strain in developed countries, usually transmitted by beef, but many other food substances may be transmittable. Associated with petting zoos, जो animals घर में होते हैं. Low infectious dose, around 100 bacteria can produce the disease. Shigella toxin is the name of the toxin which these produce. There may be crampy abdominal pain, often disproportionate physical finding along with the blood-stained diarrhea. Complications include, again, hemolytic uremic syndrome, especially in children. There may be thrombocytopenic purpura. Then wide range including this can cause meningitis, gastrointestinal disease, urinary tract infections, wound and bacteria. The gastrointestinal infections are caused by the enteropathogenic E. coli, which are primarily in infants and children, and outbreaks in the hospital nurseries may take place or in daycare centers. Stools has mucus, but no stool identified, but not blood. It's identified by the serotyping. Enterotoxigenic E. coli are involved in the traveler's diarrhea. It's watery diarrhea without blood, usually self-limiting. Usually the organism is not found. Other than patient history and lactose positive organism may be seen. Enteroinvasive is which produces the dysentery with bowel penetration, invasion and destruction of the intestinal mucosa. With blood, they do not ferment lactose and identified via DNA probes. Enterohemorrhagic again causes more severe bleeding and it can cause hemolytic uremic syndrome. Then enteroaggregative causes diarrhea by adhering to the mucosal surface of the intestine. It causes watery diarrhea. Symptoms may persist for around 2 weeks or so. Other organisms involved in the intestinal infection are Klebsiella, Enterobacter, Serratia and Hafnia. They are usually found in intestinal tract. Wide variety of infections can occur because of these. Primarily, they may cause other site infections like pneumonia, wound infections and urinary tract infection, which will be taken up by my other colleague. General characteristics are some species are non-motile, Simon citrate positive, hydrogen sulfide producers, hydrogen sulfide negative, phenylalanine deaminase negative. Some are weakly urease positive, and they are. Klebsiella are usually found in the GI tracts. There are 4 major species. Klebsiella pneumoniae causes pneumonia, and other species can cause diarrheal illnesses. Serratia, there are 7 species. Serratia mersensis is the only one which is clinically important, frequently found as a nosocomial infection of urinary or respiratory tract infections, and they are implicated in the bacteremic outbreaks in the nurseries, cardiac surgeries and burns, and fairly resistant to antibiotics. Major characteristics are certain biochemical characteristics. We now move to the specific topic of typhoid fever. Typhoid is a systemic infection with the bacterium known as Salmonella enterica serotype typhi. At least 16 million new cases of typhoid fever are reported each year, with around 600,000 deaths. The risk factors are the food prepared outside the home, such as the ice creams or flavored ice-baked foods from street vendors, or drinking of the contaminated water, having close contact or relative with a recent typhoid fever patient, poor housing with inadequate facilities for personal hygiene, or recent use of antimicrobial drugs. So for typhoid fever, we can say, if we want to have a precaution, cook it, boil it, peel it, or forget it. The Salmonella enters our body, into the intestine, it multiplies there, enters into the Peyer's patches, from there it enters into the systemic circulation, bacteremic phase develops, and then it resides into the reticuloendothelial system, spleen, liver, bone marrow, etc. When it enters in the small intestine, this is the brush border epithelium, it invades the epithelial cells, bypasses the immune mechanism, and comes down to the subepithelial layer, from where it is taken up by the macrophages and then delivered to the reticuloendothelial system. The pathogenesis, that the organism is taken up by the macrophages, from where it is delivered to the mesenteric lymph node, and from there through the blood into the spleen and into the liver, and from gallbladder it passes on to the GI tract again, and then to the Peyer's patches, where it causes its lesion. During this all phase, we start developing our antibodies. Initially, it is the IgM which comes into in just few days of the onset of infection, and later on IgG appears. IgG lasts for more than few weeks, whereas IgM may vanish by 4 to 6 weeks. The fever is the main characteristic feature of typhoid fever. Its onset is gradual, sometimes it may be sudden. Usually it runs a pattern what we call step ladder pattern. Initially the temperature is low, but as the day passes the temperature starts rising further. Duration is usually short, maybe few days. Characteristic, as I mentioned, step ladder. When it reaches its peaks, it's a high grade fever. The person may complain of chills and rigors and is associated with certain GI symptoms. In Pakistan, a fever without evident cause that lasts for more than a week, one should consider typhoid until proven otherwise. The other differential diagnoses are many, but seasonally we consider malaria on top. Typhoid fever, the Salmonella, is a human-specific pathogen. It's a member of Enterobacteriaceae family, serologically positive for its antigen known as lipopolysaccharide antigen, which are O and H antigen, and the flagellar antigen, which is H antigen, and a polysaccharide capsular antigen known as VI or virulence antigen. The infectious dose varies between 1,000 to 1 million organisms. The VI negative strains are less infectious than those which are VI positive. A low gastric pH may play an important role in the development of the disease. Typhoid induces systemic and local humoral cellular response, but these confer incomplete protection against the relapse or the reinfection. The clinical features that the most patients present to the hospital with typhoid fever may be children or the young people between the ages of 5 and 25. Between 60 and 90% of people with typhoid do not receive medical attention or are treated as outpatient. Incubation period varies from 7 to 14 days, or it may range from as low as 3 days to as long as 2 months. There may be, along with fever, influenza-like symptoms like body ache, myalgia, arthralgia, etc., associated with chills, sometimes rigors, a dull frontal headache, anorexia, nausea, poorly localized abdominal discomfort and pain. Some people present with respiratory symptoms of dry cough, and muscle aches may be there. There may be few physical signs initially. When we find these, there may be a coated tongue, a tender abdomen, the viscera may be enlarged, liver and spleen. A significant feature is relative bradycardia. Normally, with 1 degree rise of temperature, we have a 10 beats increase in the heart rate, but here, with each degree rise of temperature, we do not get a corresponding increase in the heart rate. This we call as relative bradycardia. Unusual for the patient hospitalized for typhoid have no abdominal symptoms. Another feature of this disease is rose spots, which are papular rashes which come in crops seen in the upper abdomen and the lower chest. These are the rose spots. Then there may be a history of intermittent confusion when the involvement of CNS may take place, and the patients have a characteristic apathetic effect. This occurs usually in the 2nd to 3rd week of the illness. This is what a person would look like when he has the features of CNS involvement. The temperature pattern, as I mentioned earlier, that initially it is low grade but gradually rises. In the 2nd week it sustains, 3rd week sustains, and by 4th week it enters into a defervescent period. With the interruption of antibiotic, it comes down by the end of 2nd week. But sometimes you can have a relapse by the end of 3rd week or early 4th week. How to investigate? We do the routines. The hemoglobin level, white cell count and platelet counts may be usually normal, or if the illness is little prolonged, it will be reduced. There may be some changes in the liver enzymes. Blood culture is one of the methods of diagnosing, but the yield varies between 65 to 85%, and that depends also on the clinical phase or clinical duration of the illness. Usually the bacteremia is seen between the 7th to 12th or 13th days of the illness. So its positivity is little low, but bone marrow culture is more sensitive because it resides in the bone marrow, and one can culture the organism from the bone marrow even after the person has been started onto an antibiotic. So yield is up to 95% in cases of bone marrow. Even in patients who have been taking antibiotics, as I mentioned, for several days, you can culture the organism from the bone marrow. Another immunological test is Vidal test. Its value is little controversial. I mean, these days we have got better tests to diagnose the disease. Cutoff value usually is 1 greater than that, but a coupled reading in which we have a 4-fold increase can also be diagnosed. For example, if you have done in the earlier phase of the illness and you have found the Vidal test to be 1 in 80, and then after a week or so when you repeat, if you find it to be 1 in 320, then that is diagnostic. Typhoid test is sensitivity is 70 to 80%, but the specificity is greater. And these days in clinical practice, we usually do Typhoid in which we identify the IgM and IgG antibodies. We can also do a VI agglutination test. PCR tests now these days are very common for many diseases, so this can also be done. If the patient remains undiagnosed or untreated, or if the antibiotic has not worked properly, then the person may enter into the complication. Around 10 to 15% of patients may develop one or the other complication, and usually this occurs something like after 2 weeks of the current illness. There may be gastrointestinal bleeding, intestinal perforation, typhoid encephalopathy are the most important things that could occur. Up to 10% of the patient can bleed, and severe bleeding can occur in up to 2% of the cases. Intestinal perforation can occur into up to 1 to 3% of patients who are hospitalized with intestinal perforation. An acute abdominal or worsening of the abdominal pain, an increase in the pulse rate, a fall in the blood pressure. In a sick patient, one should suspect that the person has a bleed or intestinal perforation. Relapse can occur in around 5 to 10% of the patients, usually 2 or 3 weeks after the initial illness of resolution of fever. Usually this attack is milder. Same antibiotic susceptibility pattern may be useful. Because of the endemicity in our part of the world, reinfection may also occur and can be distinguished from the relapse by molecular typing. Each time you may have a different strain. Up to 10% of convalescing patients with untreated typhoid excrete the organism in their feces for up to 3 months. So a complete cure can be diagnosed, or for the research purposes, we do a stool examination to see if the person has entered into the carrier state. Up to 25% of long-term carriers have no history of typhoid. Probably they develop a subclinical infection and then they enter into a carrier state. More common among women, and one famous lady, Typhoid Mary, was there in US in early last century, who was responsible for spreading the disease in about 25 cases. Now this remains in the gallbladder, and when the person develops cholelithiasis, the organism may be found in the stone. If a person who is found to be index case for a carrier state and has on ultrasound cholelithiasis, this becomes an indication for cholecystectomy, an elective indication for cholecystectomy. Among hospitalized patients, the case fatality rate varies from 2 to 10% in Pakistan. As I mentioned earlier, the typhoid diagnosis, the differential diagnosis for typhoid would be malaria. The abscess is deep-seated, maybe liver abscess, maybe bone abscess, or something like that, and abdominal tuberculosis. And a condition, sometime, because of the seasonality, you may have dual infection, that is both the typhoid and malaria both occur together. To treat such an infection, we need to use antibiotics, and we need to see what are the antibiotics that are good. So the antibiotic or antimicrobial drug should have certain characteristics. Selectively toxic to the microbe and non-toxic to the host cells. It should be microbicidal rather than a microbiostatic. Relatively soluble and functions even when highly diluted in body fluids. That means it should spread all over the body. It should remain potent long enough to act and is not broken down or excreted prematurely. No subject to the development of antimicrobial resistance. Complements or assists the activities of the host defense mechanism. and the drug should remain active in the tissues and the body fluid, should be readily delivered to the site of infection, not excessive in the cost, does not disturb the host health by causing allergies or predisposing the host to other infections like fungal infections or others. And from that point of view, quinolones are a good choice. Quinolones so far have been developed and as the time passes and as the new drugs come up, we have got the first generation, second generation, third generation, and the fourth generations. And among the second generation, ciprofloxacin is a drug which is most potent versus certain abnormal organism, I should say, like Pseudomonas. Ciprofloxacin has become a remarkable success story in the pharmaceutical industry, not only for being the first oral antimicrobial drug with broad spectrum that can be used to treat day-to-day as well as serious infection, but also for its penetration into the commercial marketplace. This is the structure of ciprofloxacin. The spectrum this drug shows amongst the gram-positive organism, it is active against most of the staph. Even the gram-negative, it's effective against E. coli, Haemophilus influenzae, Klebsiella pneumoniae, Neisseria gonorrhoeae, Proteus mirabilis, Salmonella typhi, Serratia, Shigella, Moraxella catarrhalis, and Pseudomonas species. And also it is effective against atypical respiratory pathogens like Legionella pneumophila, Mycoplasma pneumoniae, and Trachomatis. This is most active of quinolones against Pseudomonas, more active than ofloxacin against Moraxella and Chlamydia, greater in similar activity against Neisseria with cefotaxime or ceftazidime. Salmonella typhi resistant strains are susceptible to ciprofloxacin as active as ofloxacin against staph. So the treatment for the with this drug is effective, safe in all age groups, rapidly effective. This is a relatively old study, but around 67,000 isolates in USA, most from the Enterobacteriaceae species, some Staphylococci and Pseudomonas are still susceptible to Cipro. One feature of the drug is AUC-MIC ratio. AUC is area under curve versus MIC ratio. So the drugs which has got greater AUC-MIC ratio are more effective, and Cipro shows AUC-MIC ratio against these organisms to a greater extent. When compared with ofloxacin, again AUC-MIC ratio is higher for ciprofloxacin as compared to ofloxacin in E. coli, Klebsiella, Enterobacter, Proteus, Salmonella, and Haemophilus influenzae. So it is the most potent fluorinated quinolone, has a very broad spectrum of antibacterial activity. It ensures a rapid bactericidal activity at very low concentration and is rapidly distributed, and adequate levels are achieved in most tissues of the body fluids with high intracellular concentrations in the phagocytes. Good bioavailability with an extended half-life elimination. This exhibits effect against most organisms. AUC-MIC ratios for most pathogens are greater than 100. The maximum concentration is there. Has proven efficacy in many types of systemic infection, including the typhoid infection. Available as tablets as well as IV. Convenient twice daily dosing, and is well tolerated by the patients. To control the typhoid fever, we need to have a safe drinking water facilities, effective sewage disposal facilities, hygienic food preparations. Water for drinking should be boiled or bottled. Food should be thoroughly cooked, and ice cream should be regarded with suspicions. Various vaccines are available, oral vaccines and injectable vaccines for the prophylaxis. Parenteral VI based vaccines, single dose vaccine, and booster dose may be given. So the message is cook it, boil it, peel it, or forget it. Fluoroquinolones are the drugs of choice to treat gastrointestinal infections, including the typhoid. Conclusion is think and listen to the patient. Use your clinical acumen. GI infections are very common. Use antibiotics in full dose. The drug of choice of patient with typhoid is ciprofloxacin twice a day. We have to fight back against the oral infections through clean water. Don't use chilled food, use cooked food, and separate these things. Please wash your hands to get relief of the bacteria. Thank you very much for listening to me with such questions.